in individuals who disease has progressed on checkpoint blockade who do not have an actionable oncogenic driver, the standard approach is chemotherapy. And the same principles apply to that individual as they would apply if they were treated up front, were chemo naive and received chemotherapy as our first line approach. This individual is still fit. The seizure presumably has been treated with anticonvulsant therapy. He's receiving whole brain radiation. Assuming performance status is not deteriorating, I would still favor a 2-drug combination with platinum and some partner agent. And the standard agents in this setting include taxanes and gemcitabine along with carboplatin. And some may prefer solvent-based paclitaxel, others may prefer docetaxel. My go-to agent, particularly in the elderly with squamous cell, is nanoparticle albumin-bound paclitaxel, given weekly with carboplatin. So in my experience, at least over the last 3 to 4 years where I routinely started adopting nanoparticle albumin-bound paclitaxel since about 2013, I've been pleased with both the efficacy and toxicity profile. By and large, this drug is a bit easier to give than solvent-based paclitaxel. It takes half an hour tops, does not require pre-medication. The incidence of neuropathy is generally a bit lower, and when the drug is stopped, neuropathy will mitigate and sometimes reverse a lot more quickly than we see with standard solvent-based paclitaxel. A weekly regimen, by and large, I see a bit less myelosuppression compared to our conventional Q3 week approach. In terms of response rates, the literature, at least in squamous cell, documents about a 44% response rate. My own personal experience pretty much matches the numbers seen in the phase 3 trial. And the median progression-free survival, by and large, is a minimum of 6 months. There is now an ongoing randomized phase 3 trial, squamous specific, that is looking at 4 cycles, 12 weeks of NAB-PAC with carbo, and then a randomization, either maintenance NAB-PAC alone, single agent, or observation. That trial is continuing to accrue. And in the context of the elderly, we have looked at, in the Abound 70 program, 2 different schedules of NAB-paclitaxel and carbo. One, the conventional weekly uninterrupted approach. The other, 3-week out of 4 schedule, very similar to a prior paclitaxel carbo regimen or schedule that was investigated in Europe by Qua and colleagues in France. So the big question is, can we give this agent more safely in the elderly using a 3-week on, 1-week off approach, help mitigate toxicity and yet preserve response rate, progression-free, and overall survival? And those data are just being assessed. Individuals with advanced lung cancer really need to be addressed holistically. It's not just a matter of using chemotherapy to attack the cancer. We have to look at the entire patient. There's a very important paper by Jennifer Tamel, published in the New England Journal around 2011, that looked at proactive, preemptive supportive care versus our more usual reactive, symptom-generated approach. These were individuals, all with advanced disease, who at the time of diagnosis were randomized to a monthly meeting with a supportive care, palliative care team, included pain management specialists, nutritionists, social work, various approaches toward anxiety and depression. And the control group got standard treatment. So chemotherapy, if they happened to have a complaint, they would then be referred to the appropriate specialist, but they weren't seen in a proactive, preemptive manner. The group that received the preemptive integrated approach did far better. They had much less anxiety, much lower rates of depression. They were much less likely to be hospitalized toward the end of their lives. They had lower hospitalization rates, much more appropriate hospice use, and then the icing on the cake, they lived longer. Their median survival was more than 2 months greater than the reactive group. Problem is, it's not a drug, so there's no reimbursement for this approach, or inadequate reimbursement. But needless to say, if any systemic agent had generated similar survival benefits, we'd be talking about a multi-million-dollar blockbuster. So this form of preemptive action, of simple involvement, holistic approach toward the patient, not just the elderly patient, but any patient with advanced disease, I think is highly warranted, and we have phase 3 data that justify its proactive use.